Thank you very much, Michael. Kalimera, good morning, and thank you to the organisers for the invitation to participate in this meeting. So these are my conflict of interest. I have no conflict of interest to declare, but my declaration of interest is that I'm the president of the new UK Maternal Cardiology Society. So I'm speaking today about pregnancy with valvar stenosis. And we've already seen by the previous speaker has showed the cardiovascular changes in pregnancy. And there are particular relevances, of course, of this in valvar stenosis. So you've seen that cardiac output increases, that blood pressure increases, and importantly, that pregnancy is a vasodilator state so that systemic vascular resistance decreases. Added to that, and of importance, is the so-called physiological anemia of pregnancy, the large increase in plasma volume with the smaller increase in red cell mass. So hemoglobin drops, but also importantly, colloid osmotic pressure drops. And as we'll see, that is important. So the relevance to valvar stenosis here are that in patients with a valvar stenosis, either inflow or outflow, you clearly have a fixed obstruction to increasing cardiac output. It's important to assess that pre-pregnancy, if you have the opportunity, by functional capacity and by assessing the hemodynamic response to exercise. Exercise being the best kind of surrogate we can use for pregnancy. Clearly, exercise doesn't increase your blood volume, but it does increase your cardiac output. If you have valvar stenosis, large fluid shifts are poorly tolerated. So if you have volume expansion and decreased colloid osmotic pressure, that's a perfect storm for pulmonary edema, particularly in mitral stenosis. Equally, large fluid shifts the other way, so postpartum hemorrhage can be very poorly tolerated if you have a fixed outflow tract obstruction. Patients are at risk of hypotension with vasodilatation. When you're vasodilated, you keep your blood pressure up by increasing your cardiac output. If you can't increase your cardiac output, it may have a very important effect on your blood pressure. And in arrhythmia, so particularly fast atrial fibrillation in mitral stenosis, you may have further deterioration. So all the normal physiology of pregnancy has very important implications if you have valvar stenosis. So you can assess maternal risk in several ways. You can assess by scores, you can assess by condition-specific data, which in some conditions is more significant than others, and in some conditions is very limited. And you can use basic physiology principles as we've just been discussing. All the risk scores include points for left-sided valve obstruction, indicating its importance. But importantly, scores can both under and overestimate risk. This is a nice paper from Hart, which shows that at higher predicted risk outcomes, the actual predicted risk is twice the actual risk. So this is a group of women where the risk scores were used to predict here on the x-axis and then compared with the actual outcomes on the y-axis. And you can see that at higher predicted risk, the predicted risk is twice the real risk. So if it was a perfect model, you'd be up the straight line in the middle. So as the previous speaker has indicated, probably the most useful indicator is the modified WHO classification, which was shown in the 2018 ESC guidelines. And that uses both risk scores and lesion-specific data. These are the 4 risks, and I've just put next to them where some of the valvar stenotic diseases fall. So mild pulmonary stenosis, for example, falls in risk class 1, which gives you very little, no detectable increased risk over the general population. You then proceed through class 2, where you've got mild mitral stenosis, moderate pulmonary stenosis. By the time you get to class 3, with significantly increased risk of maternal mortality and severe morbidity, this is the women with moderate mitral stenosis, with severe aortic stenosis, but no symptoms. And then by the time you get to class 4, where really pregnancy should be seriously reconsidered or contraindicated, you have the women with severe mitral stenosis and severe symptomatic aortic stenosis. So let's start by talking about the specifics of some of these lesions. So the physiology of mitral stenosis, clearly, as I've said, blood pressure is cardiac output times total peripheral resistance. So if you've got a fixed problem with your cardiac output, then you are going to have a problem keeping your blood pressure up in a vasodilator state. Systole is a constant length. So if you have a tachycardia, then your diastole shortens further, and thus your ventricular filling suffers even more. If you have fast AF, that reduces your filling and your cardiac output, and thus your blood pressure. So the physiology of mitral stenosis gives you a reduced cardiac output, plus the increased LA pressure and the reduced colloid osmotic pressure gives you pulmonary edema. This is how you classify mitral stenosis, as you'll all be aware. So a combination, mild, moderate, severe, on a combination of valve area on planimetry and mean gradient. So pregnancy outcomes in mitral stenosis. This is a very nice meta-analysis from Heart last year, which was a meta-analysis of all heart valve outcomes in pregnant women. But of interest, and I mentioned earlier about the amount of evidence, it was only in aortic and mitral stenosis that the authors found a significant enough number of good quality studies to actually be able to draw conclusions. And this is a really nice infographic talking about the outcomes in this meta-analysis. So on the top here, severe mitral stenosis, 3% maternal death, more than a third of women having pulmonary edema, 16% of women with new or recurrent arrhythmia, which is predominantly atrial fibrillation. Fetal outcomes, we have still a 4% stillbirth rate, 2% neonatal rate, and a rate of preterm birth, a lot of which was iatrogenic. When you're in, let's try to get rid of the pointer, moderate mitral stenosis, still a maternal death, but less maternal death risk, 1%, 18% pulmonary edema, 5% atrial fibrillation, still a risk of stillbirth, no neonatal deaths, and preterm birth. So both moderate and severe mitral stenosis with significant impact on maternal and fetal outcomes. And importantly, in the ROPAC study, it was identified that pre-pregnancy symptoms are an independent predictor of maternal cardiac events. So even if you've got moderate mitral stenosis, if you are anything other than NYHA1, then that is a predictor of maternal cardiac events, which leads us to talk about management. So these are the ESC 2018 guidelines for management of mitral stenosis, to which I've added some further thoughts of my own. So if we're talking pre-pregnancy, and obviously we always want to see these women with known mitral stenosis pre-pregnancy for assessment, but sometimes pregnancy is the condition that unmasks the previously unknown mitral stenosis. So it's clear that you intervene pre-pregnancy in severe mitral stenosis, but I would also say symptomatic mitral stenosis, and that this should also be considered in moderate asymptomatic mitral stenosis, particularly if the valve is suitable for balloon valvuloplasty. So symptoms push you into the category of definitely needing pre-pregnancy intervention, but even if you've got moderate disease and you're asymptomatic, if your valve is suitable, then I think that should be considered pre-pregnancy. And you consider intervention on the mitral valve during pregnancy if you have failure of all medical therapy and refractory symptoms. So medical treatment, important to improve LV filling by beta blockade. What you're looking to do, obviously, is slow the heart rate, increase the diastolic filling time, improve the LV filling, reduce the left atrial pressure. Treat pulmonary edema with loop diuretics as normal. Anticoagulation, again, the guidelines clear that should be done in the case of atrial fibrillation, in left atrial thrombus, or in prior embolism. I would add to that serious consideration of anticoagulation for a dilated left atrium, even in sinus rhythm, or the presence of spontaneous contrast on the echocardiogram. Vaginal delivery in the majority, none of these stenotic valve lesions definitely need a caesarean delivery. Caesarean delivery should be considered if there are severe refractory symptoms and you can't improve the situation by balloon valvuloplasty. So the key management points are intervention pre-pregnancy or during pregnancy, beta blockers to improve filling, diuretics to treat pulmonary edema, and anticoagulation. And the vast majority of women plan vaginal delivery unless you're in a situation of severe refractory symptoms. Same meta-analysis, outcomes of aortic stenosis. So again, top severe, moderate bottom. So we have a 2% maternal death rate in severe aortic stenosis. So this is a valve area of less than 1%, a gradient of more than 64 millimeters of mercury on echo. Pulmonary edema around 10% and a small incidence of new arrhythmia. Again, some impact on the fetal outcomes. When you get to moderate aortic stenosis, no maternal deaths reported in this meta-analysis, still a small amount of pulmonary edema and arrhythmia, and still preterm birth, most of which is iatrogenic. So pre-pregnancy assessment for aortic stenosis, a woman should tolerate pregnancy well if she is asymptomatic with a normal left ventricle and normal exercise hemodynamics. Those are the absolutely key points. It's assessing the exercise hemodynamics. Is there a normal blood pressure rise? And is she asymptomatic with a normal LV? Additionally, the peak gradient should be less than 80. That's a mean gradient of less than 50. And the aortic valve area, ideally more than 1, but not always. You can have an aortic valve area less than 1 and meet the other conditions. If you don't meet these conditions, then she should have intervention preconception, whether that's balloon valvuloplasty or aortic valve replacement. If symptoms occur during pregnancy, then you need to try and reduce the cardiovascular requirements, so bed rest, beta blockers, oxygen, treat any other contributing factors like anemia, and balloon valvuloplasty, as you can see in the picture, is possible during pregnancy, but you need to think about the risk of aortic regurgitation. Surgery, as you know, possible, but generally the last resort. It's really important when following these women by echocardiography during pregnancy to remember that it's normal for the gradient to increase during pregnancy with an increase in cardiac output through a fixed obstruction. In fact, if the gradient doesn't increase in pregnancy, you need to worry about whether the left ventricle is coping with the pregnancy level. I'd just like to share a case with you. This is a case of one of my patients with a bicuspid aortic valve. She was referred to me when she was 29. She'd been under follow-up elsewhere for her bicuspid aortic valve for many years. The aortic peak gradient was around 40. She had mild aortic regurgitation, a normal left ventricle, and her aortic root had always been measured at around 3.3 centimeters, so normal. She had her first pregnancy aged 16 and was delivered then by elective cesarean section. I think probably because of the aortic peak gradient, although this clearly wouldn't be the standard management or meet guidelines now. So this is how she was in a previous hospital. She was referred to us several years later. At the age of 29, referred from her local hospital at 36 weeks because of anaesthetic concern about her aortic stenosis. The aortic valve was unchanged. The gradient was 40, moderately stenotic, so mild moderate border. The left ventricle was normal. The ascending aorta, however, was 4.3 centimeters and had been reported as 3.4 centimeters 3 years before. So, of course, the key questions here are where had the aorta been measured and was there really a change? Because if there's a change of a centimetre in 3 years, that's very significant. But actually, as you can see at the bottom here, the first picture, the classic aorta of the bicuspid valve, where the widest point of the aorta is well up the ascending and not at what you would call the aortic root, compared to the standard dog bone-shaped aorta of a patient with a normal aorta or connective tissue disease, where the widest point is clearly the sinus of Valsalva. Same patient here on MRI showing that the widest point is not the sinus of Valsalva. So I think the key point here is always know what you're looking for and make sure that the measurements are comparable, because the key point in bicuspid valve is that the aortopathy is not at the sinus of Valsalva. The sinotubular junction is effaced. The widest point of the aorta may be the ascending, and it's the widest point of the aorta, as we're going to hear, I think, in the next talk, that always defines the dissection risk, not where the widest point is. So an oval aorta may lead to an underestimator on echo, and you better follow that on MRI. The key point, as in this patient, don't just consider the valve, it's the aorta that may define the pregnancy risk and the management. As it was in this case, we had to treat this patient in the absence of being able to obtain her previous scans, as if she'd had a 1 centimetre aortic expansion in 3 years, which I suspect she probably hadn't. Bicuspid valve, 1% of the population, 10% recurrence, so screening should be offered. There is very little evidence about tricuspid stenosis in pregnancy. Tricuspid stenosis is predominantly rheumatic and predominantly part of a wider rheumatic heart disease with other valves affected. You can have isolated tricuspid stenosis congenitally through complications of pacing lead fibrosis or through carcinoid syndrome. You can also have a stenosed tricuspid bioprosthesis, which was put in for a previous reason. And all this may be unmasked by the volume load of pregnancy. And in this low flow, low pressure circulation, a mean gradient of more than 5 may be very clinically significant. That's why I would suggest considering anticoagulation in women with tricuspid stenosis in pregnancy, or even with a bioprosthetic valve, because a pregnancy as a hypercoagulable state, even a very small amount of thrombus on an abnormal valve can tip your gradient up to above something which will be clinically significant. Percutaneous valve in valve has been performed in pregnancy. There are a couple of case reports. These are pictures from one of them, where you can see that this patient had a stenosed bioprosthesis, which had been inserted several years before or after chest trauma. She had a mean gradient of 13, became extremely symptomatic with the volume load of pregnancy, very low cardiac output, and she had a percutaneous valve in valve successfully. Pulmonary stenosis, in contrast, is generally extremely well tolerated. If it's severe, pregnancy may precipitate right heart failure, tricuspid regurgitation, or atrial dysrhythmia, but in practice, this is rare. The picture here shows typical Noonan facies. So if associated with Noonan syndrome, remember the autosomal dominant inheritance. If you see the women pre-pregnancy, then you intervene on anyone who's symptomatic from the pulmonary stenosis, or if the peak Doppler is more than 64. So if you've got severe pulmonary stenosis. And balloon valvuloplasty, as in aortic stenosis, is possible during pregnancy if symptoms develop. But generally, this is a very well-tolerated lesion. So to summarize, the key messages on valvar stenosis in pregnancy are, as I'm sure all my colleagues will talk about today, that any woman with known cardiac disease should have expert pre-pregnancy counselling, assessment and multidisciplinary antenatal care. If you have symptomatic or severe mitral stenosis, the woman should have valve intervention pre-pregnancy. Beta blockers clearly are not contraindicated in pregnancy and are the first line and mainstay of management in mitral stenosis. Severe aortic stenosis can be very well tolerated if the woman is asymptomatic with a normal LV and normal exercise hemodynamics. So the actual gradient is not the most important feature here. Please remember bicuspid aortopathy. It's often the aorta that defines the risk and the management and not the valve itself. Pulmonary stenosis is very well tolerated generally in pregnancy. And as in all these conditions, in all these pregnant women, remember that pregnancy complications that happen to any woman, such as preeclampsia, postpartum hemorrhage, can also have major implications on the physiology of a woman with valvar stenosis. Thank you very much.
Thank you, Kathy. Great talk, clear and comprehensive for our audience. Are there any burning questions for Dr. Head? Or shall we leave it for the end of the session, the group discussion maybe?
I would like to make a comment, Michael.
Yeah, very clear, of course. This is Professor Davlouros, Kathy, and colleagues who is the head of cardiology at Patras in Peloponnese. Off you go, Pericles.
Thank you very much for the excellent presentation, Dr. Head, in which you exemplified how stenotic lesions are poorly tolerated during pregnancy. Actually, pressure overloading, meaning increased afterload for any of the ventricles, right or left, is poorly tolerated. And this, of course, includes pulmonary arterial hypertension as well. In contrast to volume loading, which is more or less more physiologic during pregnancy. After all, pregnancy is a volume loading condition, I suppose. Something that actually was impressive was the last guideline that you presented to us concerning patients with severe MS, mitral stenosis, in which case you actually said that there's no need for cesarean section, and most of these patients can actually go on with vaginal delivery, which I will consider a violent and sudden increase and decrease in afterload, increase and decrease in heart rate due to the multiple Valsalva maneuvers that will happen during vaginal delivery. And we know that an increased heart rate, especially during the Valsalva release, will be detrimental for such patients. So I will be very cautious in severe MS in advising a physiologic vaginal delivery. Is there something that I didn't understand? Was that the actual guideline that you gave us?
So I think you're absolutely right in what you say. I think perhaps I should clarify that if you are, the women who should have a consideration of a cesarean section would be those who are still symptomatic at the end after all your medical and interventional manoeuvres. I think if you're in a situation like that, you're absolutely correct. Other than that, I think, have I got an echo on? I'm sorry. Perhaps if I can see. Can you hear me okay?
Yes,
because I've lost my own screen. So I think that it's an individualized decision. I think the point I wanted to make is that the presence of mitral stenosis in itself is not an indication for elective cesarean section. It's a symptom and individually led discussion and assessment for every woman. But if you have somebody who, and clearly if you've got somebody who still has pulmonary edema despite your medical management with beta blockers and diuretics and your consideration of a balloon valvuloplasty in pregnancy for refractory symptoms, then those are the women that should be considered for having a cesarean section. But I think if you have somebody who is asymptomatic with your medical manoeuvres, who you can consider giving an epidural anesthesia, which is low dose and slowly titrated so that you don't cause significant significant drop in peripheral resistance and critical impact on the blood pressure, then I think you can consider a vaginal delivery in a controlled situation there, but very much somebody who you have abolished all symptoms with your medical management during pregnancy. So you're quite correct. If you've got somebody who is still having any kind of symptoms or in any way compromised, then they should be considered for cesarean section. But I think it's all an individual decision for the individual case at that stage, isn't it?
Thank you.